Good evening to all. So I'll directly go to the case. So as a surgeon, we should again go to first year and see the anatomy. Unless you know the anatomy, you are not able to recreate what you have to. So anterior horn medial meniscus is quite anterior on the tibia. Anterior horn lateral meniscus as shown by Nagaraj. Rare to have that tears. Usually either you do it iatrogenic while you do ACL tunnels or while interlocking nailings. But posterior horn medial meniscus is quite common, which you have seen, and rarely you see also the posterior horn lateral meniscus root avulsion. So posterior horn lateral meniscus root avulsion is usually predominantly traumatic in nature, and medial meniscus roots are usually degenerative in tear, which are seen in old people. So keep that in mind. Second, pivot shift phenomena we all are talking about. So it's not only that it's whole ACL injury, it can be the anterolateral complex injury, it can be a ramp which can lead to pivot. And don't forget to see that if it's a posterior horn lateral meniscus root avulsion, you also suspect, if you have a pivot, suspect ramp, posterior horn lateral meniscus root or anterolateral complex. Look out for all these three if you have a significant pivot shift. So combined lesions, so roots, they don't only have a proper chondroprotective mechanism. If there is a root tear, it's like a total meniscectomy because the whole hoof stresses are gone. The meniscus extrude out of the joint and increases the contact pressure and lead to osteoarthritis. And we all know lateral compartment, because of convex and concave in nature, the bony anatomy, any loss of meniscal tissue is more detrimental to the cartilage and will have more chondral lesions. So lateral meniscus has to be saved more compared to medial meniscus whenever you have a tear. And this meniscus not only is chondroprotective, but they also provide stabilization to the knee joint. So always look out for all those ramps and roots and try to repair those, because it adds to the stability of your ACL reconstruction. So this is a 29-year-old male. He's a weekend cricket player. Pain and instability in the knee since 3 years. He had a history of fall while playing. So clinically the alignment was normal, full ROM, Lachman grade 3. Pivot grade 3 and without anesthesia. So if you are getting that kind of pivot, be careful, because rarely in OPD basis you get pivot shift because they are very apprehensive. But if you are getting that, your mind should start thinking whether it's a ramp, anterolateral complex or root. So this is the MRI of that patient, and if you carefully see this image, you don't see any meniscus on the lateral side, medial side. So there's a ghost sign which says that there is a posterior on root avulsion. And if you follow that, there is no ACL, and even just as you pass, there is no root seen in the posterior lateral aspect. So there is a root tear here. Rarely you can appreciate this root tear of lateral meniscus on MRI. So you need to have that strong suspicion in your clinical examination. So look at the images very carefully, see the ghost sign, and then you will be able to pick up the meniscal root tears very well. In coronal, you rarely able to see, except medial meniscus can be seen, but lateral meniscus root avulsion is very rare to see in the coronal images. So this is what you see on the scope. Almost a radial tear, very small flimsy tissue, very small. If you can preserve that, it's well and good, but it's a chronic case. In acute you are able to preserve, but in chronic it's rare. And you can see here the whole meniscus has gone, and you can see complete the posterior tibial margin. So it's a chronic tear, ACL, leading to both meniscus root tear. So the options are, definitely you have to repair and do reconstruct. The sequence wise, I'll let you know how I move ahead. So first thing, you have to take a lasso loop, what Nagaraj and everyone said. Usually you have to take 2 lasso loops, either with tape or wire or both tapes. But this was a young gentleman and the tissue quality was good. So I took 1 lasso loop medially and 1 laterally. The trick is, the bite should be into the meniscus substance and as posterior as possible, because if you see the triangle, this is the substance where you have very good meniscal tissue. So you won't have that problem of cut through. If you are even in the zone 2 or zone 3, in the white or red-white zone, there are high chance that it may re-tear. So try to be as posterior in the meniscus when you are doing root repair. Take a bite. So for making a tunnel, you have to prepare the footprint as has been shown by various. For making a tunnel for posterior horn lateral meniscus root, you have to be in line with the ACL tunnel. Exactly in the center, as I have shown you my first slide, the lateral meniscus posterior horn root is attaches on the surface of the tibia exactly behind the ACL in between the two tibial spine, and the medial meniscus root is behind the medial tibial spine and not exactly in the center. So understand the anatomy so that you make your tunnel accordingly. So if you see, this is a simple ACL jig where you can make the tunnel exactly in the center, just behind the in front of PCL, but behind. Then you have to prepare the footprint, and then you see the tibial tunnel for the medial root is not in the center, it's posterior to the medial tibial spine. So before you make, you need to prepare the footprint, and as I told you, see that the bite is in the posterior aspect, about a centimeter away from the bad tissue, so that you don't have a cut through. And then you just shuttle relay it on the tibia, and then you fix it on the tibia. Now being you have to make a 3 tunnels here, one for medial root, one for lateral root, and one for ACL. How to avoid tunnel coalescence is important here. So what I did, for the medial meniscus root repair, I have kept the jig at the maximum angle of 65 to 70 degree, so that it's quite low. Then when it comes to, and I don't use 4.5 mm jig, it's only a simple 2.4 mm bead pin. For posterior horn lateral meniscus, the angle went up to 60-65, less than that, and little more medial. So the first this medial meniscus is right next to the tibial tuberosity with a long angle. The next is the lateral meniscus root, little medial with the angle shorter than that. And the third is the ACL, which is at 50 degree and quite anterior. So it forms a sort of triangle there, which you can avoid tunnel coalescence. And I only use 2.5 mm bead pin. That much of tunnel is enough. No need to make it bigger, because you can easily shuttle relay with that small tunnel. And this is how you look it from above. This is for ACL, this is for lateral meniscus, and that's for medial meniscus. And that's how it looks from outside. This is lateral meniscus, this is medial meniscus, and that's for ACL, and you can easily fix them and then go and do a slow rehab to them. So I was just searching the literature, very few, and this is the recent article published in 2023. They have made tunnel all the way from the medial side only, and they have used a single anchor to tie both the roots and separate for ACL. Another technique which Dr. Bancha has published, he had taken the tunnels from anterolateral aspect, and for ACL the same, but he has used only a single post to tie all the 3. So very rare to see, and only few articles are seen there. Another one where there was a root avulsion, bony avulsions. So this is what a triangle technique which we have developed for that rare injuries. Thank you.